Good afternoon. I suspect a few more people will be walking through, but I do want to try to get us started on time so we have full time for the presentation and the question and answer period that's going to be at the end. For folks who don't know me, my name is Mark Snowden. I'm the Chief of Psychiatry here at Harborview and the Vice Chair for Clinical Services for the department. And it is my pleasure to welcome you to the next in our Ripley Memorial Lecture Series of Grand Rounds and to introduce our speaker today. Dr. Carol Bernstein completed her medical school training at the Columbia University College of Physicians and Surgeons. Following an internship in internal medicine at St. Luke's and Roosevelt Medical Center, New York, she completed her psychiatric residency training at Columbia University and the New York State Psychiatric Institute. Dr. Bernstein is active in many national psychiatric associations and has served as trustee at large, as treasurer, as vice president, and as a past president of the American Psychiatric Association. She's in the American College of Psychiatrists, where she's currently the treasurer of the Board of Regents for the Group on Advancement of Psychiatry and the American Board of Psychiatry and Neurology. In 2003, Dr. Bernstein was selected as a fellow in the Executive Leadership in Academic Medicine, a national program designed to promote leadership for women in medicine. In 2005, she completed the Physician Leadership Development Program at NYU, as well as the Graduate Medical Education Leadership Program of the Accreditation Council for Graduate Medical Education. From 2010 to 2016, Dr. Bernstein served on the board of directors for the ACGME, where she also chaired the ACGME Task Force on Physician Wellbeing. She's a member of the Action Collaborative on Clinician Wellbeing and Resilience of the National Academy of Medicine. In addition to numerous articles and national presentations, and even though she's not going to talk about it today, I just had to remind people that she hosts a weekly call-in radio show on Sirius Radio for the public. So join me in welcoming Dr. Bernstein today.
Thank you, Mark. It's really a pleasure to be here. I don't think I've been in Seattle for a long time. I think I was here in the 90s. I was sort of trying to remember, but I think it was before my daughter was born, so it was a long time ago. But it's a particular pleasure to be here, and I want to thank your chair, Jürgen, for inviting me to give this talk on a topic that I think is of great interest to all of us in medicine these days. So, you know, I keep changing the title a little bit, but I'm going to try to address issues of stress, burnout, depression, peripherally suicide, some of the things that we're going to do about it. It's going to be a fairly comprehensive talk because I just feel it's really important to see all aspects of the elephant, not just the trunk or the tail. So I hope you'll bear with me and I'll talk fast so there's time for questions at the end. That's who I am. These are the objectives, just to identify key factors contributing to stress, burnout, well-being really, and resilience among trainees and faculty, to describe the complex interrelationships between burnout, depression, and resilience, and how these factors may interact with each other as a result of pressures, particularly in the academic medical center, because that's where we are, and to identify our beginning attempt to address these issues both individually and systemically. There are no disclosures at the moment. I'm actually in between jobs, so I'm not even salaried. But most of the time, I say that the disclosure should really reflect who pays your money. So anyway, that's just fine. So we are psychiatrists in this room, and you know, we like to tell stories and provide narratives. So I thought I'd tell you a little bit about how I got involved in this. My whole career really has been in medical education. But as Mark was mentioning, I was on the board of directors of the ACGME in 2014 when two medical interns at two different hospitals in New York jumped to their deaths and died by suicide. And I will also mention the reason I say 2014 to 2018 is that tragically last May, there was the death of a fourth-year medical student at NYU and a second-year resident in my program. So I started at this listening to issues for other people, but this has become a particularly personal story for me. And trying to understand what has been going on, both about the relationship between depression and suicide and burnout to depression, a lot of which gets confused and is still getting confused as we start to talk about this. I do believe in my thinking at the time when the ACGME was talking about this, and I just happened to be the only psychiatrist in the room. I was the only one that was there, and I'm thinking, oh my goodness, if we can get doctors to look this way at themselves and their emotional lives, then they will pay more attention to our patients who are struggling with psychiatric illness. And that was really the reason that I started to get so invested in it. But as you all know in this room, suicide is really only the tip of the iceberg. And what's underneath it, all right, a lot of things: anxiety, helplessness, stress, depression, insomnia, all of that. And we understand that. I mean, there's been a lot of focus on this because of deaths, but as we know, it's the tip of the iceberg, and we can't always prevent suicide. And that's been, I think, a very particularly challenging issue for people to address in our field. This is not a new problem. The AMA consensus statement on physician well-being happened in 2003 when the AMA brought together a whole lot of people to talk about problems of mental health and concluded that the culture of medicine accords low priority to physician mental health despite the evidence of untreated mood disorders and the burden of suicide. They identified barriers to treatment, discrimination in licensing, hospital privileges and advancement, and recommended transforming attitudes and changing policies. And what happened? Nothing. But, you know, as things happen in life, I think we're really at a tipping point having to do with a lot of other factors in addition to these problems that have existed for decades. So this slide, which is a little bit hard to see, I know in the back, I see you have bus shelters here when people are even right outside where you're getting your buses around the city. So there's a bus shelter right outside of Bellevue. And when I was starting to get involved in this, one of my residents took this picture and said, "What is this?" It says, "Born to stay strong, time to help my patients, no time to be tired." And then a little tiny print, "See how we can help." And it was like, what? I mean, the AMA is trying to do something about this, and they're, you know, I called them up and I said, "What are you doing here?" So they took it down eventually. This is what really happens. This is a picture that went viral on the internet of an emergency room doctor after he lost a patient. And these are some of the kinds of pressures that we face in medicine. This is just a really lovely picture. Christina Maslach has really been the guru of the burnout scales. This is something she put together. Whoops. Why are physicians vulnerable? I think it's really important to look at this. We have the second victim syndrome, response to an acute job trauma. Is this, you know, are there things that could be preventable? It's a response to chronic stress on the job and occupational hazard. So that can all lead to burnout. Then we have burnout can lead to depression. And I think we, more than our other colleagues in medicine, understand that these are different entities. I like to make the analogy with grief, which can sometimes lead to depression, but is not the same thing. And burnout and depression are not identical, even though some people would like to medicalize burnout. I think that that's a mistake. We know what depression is. And then, of course, any depression and other issues can lead to suicide, as we understand. I will tell you that there's been a lot about talk about zero suicide, and I try to say to our colleagues in other branches of medicine, suicide is the end point of some psychiatric illnesses, and we can't prevent suicide ultimately all the time any more than we can prevent other forms of death from illnesses in medicine. I think you all know about this, right? We know about personality disorders in psychiatry. And I think that there is the doctor's personality, the compulsive triad, that may make us particularly vulnerable: guilt, doubt, an exaggerated sense of responsibility. A lot of it is adaptive. We have tremendous commitment to patients. We have diagnostic rigor. We're thorough. We want to stay current. We recognize the responsibility of patient trust. And what's maladaptive is allocating time for families, setting limits, differentiating healthy self-interest from selfishness, difficulty relaxing, a sense that we're not doing enough, that we don't know enough, and a sense of responsibility for what cannot be controlled. And Glenn Gabbard wrote about this in 1985, and I'm sure many of you are familiar with the paper that he wrote. Now we can look at the culture. If a well, this is I know there's been a lot in the news about planes, but if a plane experiences a near miss, the crew is grounded and the team is debriefed and supported. In medicine, if a patient dies, possibly unexpectedly in surgery, the room is clean and the team does the next case. Also, doctors struggle alone. Doctors more often than not are left alone to struggle with their suffering. Many find it hard to ask for help, to acknowledge needing it. They're trained to be independent and accountable and assume an undue portion of the miseries of others. However, I also want to say, and particularly as we sit in Seattle, in the state of Washington, work in medicine is not the same as working at Google or at Amazon. It's a profession, it's different. We have a different sense of responsibility. So all of these contribute to some of the challenges. Sorry about this with the slides. I'm just going to put all these up. These are the three components of burnout, Maslow's triad: a sense of overwhelming exhaustion, depersonalization, and feelings of cynicism and detachment, a sense of ineffectiveness and a lack of accomplishment, all contributing to a psychological syndrome emerging as a prolonged response to chronic stressors on the job. And of course, as you know, some of these feelings also occur when people are depressed, which is why, in part, burnout and depression tend to get confused so much. But what we want to say is that burnout is an individual's response to a culture, to a system. It's not something that's inherently in the individual. Now, it's the antithesis of burnout is engagement, a high sense of energy, a sense of strong involvement, pride, and a sense of efficacy. And that's all going to help counteract burnout. But in a review of 182 studies involving over 100,000 physicians from 45 countries, 142 unique definitions of burnout were used. So the burnout rates range from 0 to 80%, depending upon what you want to call it. So one of the challenges in the literature, and I've looked at the literature, is that everybody has a different definition. So, but I think we can all agree that burnout is a problem, whether you want, and I was talking to Mark about how you want to look at this here. And probably what's most important is to select a series of questions or one of the tools that we're currently using and measure it over time after you try to develop interventions. But I think it's really important for people to understand that there's no consensus about what this really is. What are the drivers of burnout? Excess stress mediated by long hours, fatigue, and work compression, as well as the intensity of the work environment, loss of meaning in medicine and patient care, decreased support, increased responsibility without autonomy and flexibility, challenges in institutional cultures, and problems with work-life integration. And for the residents or medical students or even early career folks in the audience, when I was an intern, and Andy and I were talking about this just yesterday, we had terrible hours. We worked 120 hours a week out of 7 days. There was 1 week out of 3 when I was in the hospital, 4 nights out of 7. But first of all, patients stayed for way more than 2 hours. They were in the hospital for 2 weeks, 3 weeks, 4 weeks. A lot of the patients who had complex illnesses died. And when we left the hospital, nobody could find us. Nobody had a phone. Nobody had, we didn't have email. We didn't have any of that. So the challenges then were different. But of course, one of the biggest problems now is that the patients are sicker. They're in for shorter periods of time. And everybody is expected to do whatever we did in 120 hours in much less time. So that's a lot. Those are a lot of the compression factors. This is one of my favorite slides of all time. It's the Yerkes-Dodson curve that was developed in 1908, so 100 years ago. And it talks about stress and burnout. So you have performance on the left, on the y-axis, level of stress on the x-axis. And you can see that what we want, and certainly what we want in medicine, is for people to get up to that optimal level of performance, but not fall over the other side. On the other hand, we don't want people down here. That's not going to work either. And no one's going to learn how to be a good doctor if we're stuck down here in the bottom. So it's just something that's really important to keep in mind. What are the risk factors for burnout and distress? sleep deprivation, a high level of work-life conflict, work interrupted by personal concerns, high levels of anger, loneliness, or anxiety, the stress of work relationships and work outcomes, anxiety about competency, difficulty unplugging after work, which is a huge problem now, and of course, the regular use of alcohol and other drugs. Um, there's a hidden curriculum. We all know about this. Attending medical school is a transformative experience that continues in residency. Medical culture is learned and perpetuated. Implicit teaching undermines the declared curriculum, and that relates to burnout as well as everything else. Demeaning and insensitive comments about patients, colleagues, and other specialties contribute to this. It undermines students and residents as caring and empathic professionals. And it's why we can't have this discussion just about trainees. We really have to include the staff and the physicians, just really critically important. In addition, there are long hours, high workloads, high responsibility. There's been a lot of talk about harassment and pimping, people who are short-tempered, attendings, fellows and residents alike. Everybody's told to be compassionate, but the role models that trainees see are often different. There's no civility, and the process teaches students and trainees the rules of a toxic culture in medicine. Now, these are some slides just sort of looking at burnout and work-life balance. This is a lot of the work that was done by Shannenfeld and colleagues at the Mayo Clinic. And I know it's a little bit hard to see in the back, but the blue line refers to physicians and the gold line to the population in general. And at the top, you can see that between 2011 and 2014, the percentage of physicians who were burnt out started to go up, whereas in the general population, it remained fairly steady, maybe even went down a little bit. And if you look at satisfaction with work-life balance, it's completely the contrary, that physicians saw this tanking and the general population, it was improving slightly. Burnout is especially noted in frontline specialties such as emergency medicine, general surgery, internal medicine, and urology. There's a higher risk for trainees. The academic physician piece is, I think, debatable, which I'll talk about in a minute. Women, parents, those with medical spouses. And the burnout name suggests that it's an individual psychiatric problem, but the data suggests it's a reaction to adverse work conditions. And this is a very famous slide that Shannenfeld and his colleagues put together. I just want to point out that psychiatry is up there in the green, just for what it's worth. But it's very important to read things closely. I want you to see the percent burned out down here. It starts at 35%. That's not zero, okay? That's 35%. So be very careful what you read and just see. But in general, I mean, it's a problem in medicine, and we understand that. And just hot off the presses, of course, is a redo of this study that Shannenfeld and his colleagues did that said things were getting better, that they were better now than they were then. No one really knows why, but I would suspect that part of why is that we're starting to talk about it. So people feel at least that there's somebody attempting to look at it and make a difference for all of us. And it's rising in all the specialties. Again, this is the 2011 and 2014 data, and psychiatry is here, just so you know. So, I mean, it's not that we don't suffer, but we're different than the rest. Every specialty has its own unique set of stressors and losses to overcome. In psychiatry, I think it's patient suicide. That's probably the most challenging issue that we face. And after a patient suicide, and I'm just going to make a brief comment about this in a sec, but clinicians often feel personally responsible. They feel that they've failed their clients. They second guess everything. They feel it was their fault. Trouble sleeping, feelings of self-doubt, anger, guilt, fear, and embarrassment, vulnerability to burnout, depression, and substance abuse. And it's often shrouded in a cloud of silence, even in our own field. And having been through this in my own institution with a resident, these feelings happen when one of our colleagues or someone close to us dies by suicide. And we have yet to really talk about that. And, you know, I've seen it play out in my own institution, and people, they do some very crazy things because all of these feelings really interfere with them moving on, and everybody feels guilty. Even though we tell ourselves we can't prevent it, we know that some of our patients are going to die by suicide, somehow, because we can't really do an autopsy, we can't get inside a patient's head right before they're going to right before they really kill themselves. It's very, very hard for us to get rid of some of these feelings. This is just, again, it's a busy slide, but just to show you that in general, burnout at career stage peaks in mid-career and then starts to fall off a bit. The different colored bars refer both to men and women, and you can see in general, the women are in gold. It's generally later on, it's worse for women. But what was interesting to me was this particular slide, which refers to private practice academic medicine and the VA. And the light gold is private practice. I guess because I'm in academic medicine, I assumed it was worse for us. But in fact, it's worse for people in private practice than in academia. And for those of you at the VA, it's a little bit better for you. Now, I don't know exactly why, but again, you just see that general pattern. This just repeats the same thing, that burnout increases in residency. It's high, but again, as I was telling you earlier, the criteria that are used to determine burnout are really sort of all over the place. We do know it's a problem. It's also, as I was saying to the residents yesterday, it's not a steady state. It's not something that's with us all the time. So that also makes it challenging to measure. What are the consequences of burnout? Giving burnt out care, obviously, increased risk of patient safety incidents, poor quality of care due to low professionalism, reduced patient satisfaction. In addition, this is to make the argument for the C-suite. When people are burned out, they're less productive, there are poor outcomes, there are higher costs, higher length of stay, more patient dissatisfaction, physician and staff turnover. I think one of the things that people can easily look at is retention rates, depression, substance use, divorce, suicide, medical errors, and malpractice. And of course, on the quality of care. I mean, this has been documented as well, but it's all fairly intuitive. If people are really feeling burned out in the work that they're doing, they're going to do a less good job. I don't really need to go through this for this audience, but it's something that I think we need to help explain to our colleagues the differences between burnout and major depression. That burnout, again, is an individual's response to a system, and major depression is a medical condition that needs treatment, and they're different. So I think if we don't do anything else and we can help explain this to people, that will be very important. It's often confused with major depression, and there are people in the field that want to call it a medical condition, which I don't want to do because I think we really have to address the system. And again, you know all of this. This was a very famous study that, Srijan Sen did. He's now repeated this and done this a lot over the past 10 years in many different settings. He's looked at depression during internship. And he started off by looking at a large group across different specialties. And he saw that by looking at the PHQ-9 greater than 10, and remember, that's mild depression, it's not necessarily severe, and it's a range, that before internship, interns had a fairly low rate of depression as measured by that, but that at 3 months, 6 months, 9 months, and 12 months, it went up to about 25%. And what's important about this, and I will tell you that he has now replicated this in multiple sites across the country. I don't know how many interns have participated in the study at this point, because this has been over a period of 10 years. But what's really important, and I think what's really interesting, or what he tried to look at as predictors of increased depressive symptoms. And he looked at baseline factors and within internship factors. And actually, he got money to do this study because the NIMH was interested in the genetics, not because they were particularly interested in burnout or depression. But the baseline factors that increased the risk were neuroticism, a personal history of depression that wouldn't be a surprise to any of us, lower baseline depressive symptoms. So if you were, which is just sort of interesting, women, U.S. medical graduates, international graduates were, that I wouldn't say it was protective, but they were less at risk. A difficult early family environment, again, something that we would expect, and some polymorphism on a gene that codes for serotonin transport. That's an interesting potential biomarker in depression. We'll see what happens with that. And within internship, what he saw was that people who were saying that they were depressed had higher mean work hours, perceived medical errors, and more stressful life events. Well, both of these, as you all know in this audience, if you're depressed and you're a highly compulsive person who tries to work harder, you're probably going to stay in the hospital because you can't get out, because you keep thinking you're doing a bad job. So that happens when you're depressed. And the perceived medical errors, the key word here is perceived, because again, when you're depressed, you perceive that you're doing a bad job. I do believe that there has been one study out of Harvard that tried to look specifically at medical errors in a more objective way and did see some correlation between depressive symptoms and increased medical errors. But I think the jury is still out on that one. Again, the baseline stressors, medical issues, mental health issues, relationships, family issues, financial issues, the psychological makeup of physicians that we were talking about before. Now, of course, what's going on in our academic centers here, everybody's stressed. The faculty and the staff, the push to produce RVUs, to get patients in, to get patients out, to generate revenue. And I think that's why we're really more at a tipping point about having this discussion than we were 15 years ago when it was first raised by the AMA. There's work compression, fractured care, decreasing length of stay, increasing acuity, focus on efficiency and metrics as outcome measures, difficult physician-patient encounters. I mean, this is happening a lot too. I won't even start to talk about the electronic record. Do you have Epic here? Yes, I hate Epic. Anyway, I know, it's just my little editorial comment. I know that there's a lot that ultimately will be gained from the electronic record, but it's very challenging at this particular point in time. There are gender discrepancies in suicide rates. This has been studied a lot. This has been quoted a lot, this particular study, which was published in 2004, that showed the suicide ratio for male physicians was 1.4 times higher than in the general population, and that for women, it was 2.27 times higher. But again, as we are in an age where people are more or acknowledging more that people die by suicide, I'm not really sure what this means. I'm not a fan of saying, oh, I should say this, I'm not a fan of focusing on the fact that doctors have higher or lower rates of suicide than the general population. That to me is not so important. What's really important is that we do have rising rates of suicide in the population. That's a public health problem. It's something that we need to address. And there are certain factors that make physicians vulnerable in certain ways, which I'm going to tell you about in a minute. So from 2003 to 2008, there was a very exhaustive study that was done by people looking at the National Violent Death Reporting System and looking at the differences between physicians who killed themselves and the general population. And I think that this is what's important, not whether it's higher or lower, because it's a problem no matter what. As you can see, the proportion of physicians, at least that were acknowledged to have died by suicide, was small. But it was a fairly robust study. So what was important here, and this is important, that physicians were less likely to have had the recent death of a friend or a family member. They were more likely to have had a problem on the job. They had higher measurable levels of benzos and barbiturates in their systems. Why? Because we're busy medicating ourselves. They tended to be older. They more had a presence of a known mental illness because they didn't go for treatment. So again, this is compared to the general population. And there were major barriers to help seeking diagnosis and treatment due to stigma. We all know that there still is major stigma about psychiatric illness in the world today. It's much better than it was when I was in training. People are really talking about it. High-profile people who die by suicide really raise the visibility of this as a national concern. And I think certainly that the younger generation is talking much more about things that make it difficult for them to function. But it is important to acknowledge what's particularly different for people working in the medical environment. This is the only study that I have seen in the literature, and I'm sure someone's going to look again at all of this, that looks at the incidence of suicide among physicians compared to the general population. It was published in 2008, so it's 10 years old, and it only looked at white men, so it's a skewed sample anyway. The red are the physicians, the blue are the dentists, and the dark blue are the general population. And what's of interest, and I think it's important to remember this, is that it's only in midlife that the percentage of physicians goes above that of the general population. So there's a lot of talk about losing young people to suicide, which is terrible and it's a tragedy because they're so full of promise. But if you're actually looking at the statistics, at least in terms of physicians, there's a greater risk later on in life. We could speculate about why that is. And again, as people become more open about talking about when people die by suicide, and we all know that, I'm sure many of you know of friends or family members where there was a deep, dark secret about somebody who died by suicide or had a mental illness that nobody talked about. So I think all of these statistics will change as we become more open. This is just an interesting study that was done by the ACGME, who looked at the causes of death among residents. They have all of this data. This was 14 years worth of data, 380,000 residents. Now, only 324 died in residency, so it's a teeny tiny group. But for men, suicide was the leading cause of death. For women, it was malignancies, and this was lower than an age-matched control. So there's, again, I think these efforts to talk about who has it worse aren't as important as understanding what the general issues are. Of course, there are barriers to treatment. This was a study that was published in 2010, looking at utilization and barriers to mental health services among depressed medical interns. And I don't think any of you in this room would be surprised at seeing this. There's no time. There's preference for self-management. There's tremendous concerns about confidentiality and stigma, about cost. And interestingly enough, a quarter of the folks thought treatment didn't work. I think we're doing better with that. So what's protective? People talk about resilience a lot. What is resilience? It's the capacity to bounce back, to withstand hardship, to repair yourself, positive adaptation in the face of stress or disruptive change. It's based on a combination of factors, genetics. Do you see the glass half full or glass half empty? Jürgen and I were both deciding that we were the glass half full kind of people yesterday. External factors such as modeling of others and whether you've been exposed to trauma, and also skills in problem solving and finding meaning and purpose. And this is just, again, this would be obvious to all of us in psychiatry that workplace characteristics, our social network, personal characteristics, and challenges all contribute to developing the resilient healthcare professional. There's a lot of talk about whether we can build it. So all of these factors are helpful. Realistic recognition, exercise, sleep, nutrition, supportive professional relationships, talking things out with others, good personal relationships, appropriate boundaries, a sense of humor helps a lot, time away from work, hobbies, and a passion for one's work. Now, there's been a lot of talk about the Maine thing. I know we're in Washington, but the Maine thing, Maine, it's another part of the country. The main thing is supposedly that spending at least 20% of your day on things that matter deeply to you is a core tactic to maintain wellness. So again, this is why the burnout issue is challenging, because we can all feel burned out at one particular point in time. But then if we have other things that we're doing that provide us with meaning and connection and value, it can really offset that. And they contribute to joy and engagement. And there's a lot of talk about trying to bring joy back into medicine. So, what is engagement? It's the degree of attention, involvement, and commitment to task. Obviously, it leads to good outcomes in the environment. Joy is what brought us to medicine in the first place. It's people taking care of people, listening to them, and helping them to feel better. And wellness and satisfaction result in joy and engagement in our work. So what do we need to do? These are some of the things that you can do, is to educate and increase awareness, which is what is really starting to happen around the country and may contribute to why people are feeling that they're a little less burned out than they were, because people are listening. There's a lot of talk about designating time for reflection. We know in psychiatry, we've always had, I think you have T groups, we have process groups in the residency, and they're really helpful, but I think there's a big issue here with whether we have enough time to do this. So that's a particular problem. There are processing groups, disseminating debrief protocols for seminal events. I think it's really important to have senior physicians recount both errors and problems that they've had. Last month at the annual educational meeting of the ACGME, there was a roundtable discussion at which the participants were Daryl Kirch, who is the CEO of the AAMC, Tom Naska, the head of the ACGME, and Victor Zhao is the president of the National Academy of Medicine. And Daryl got up there in front of 4,000 people in a room and talked about the fact that he had struggled with depression as a medical student. That is huge. I mean, really huge for people of that level of importance to say something. And Victor Zhao, who is not only the president of the National Academy of Medicine, but he's Chinese, and Chinese people in general are very reluctant to reveal anything personal about themselves. And he talked about how he quit his first residency. And he had never discussed this openly with anyone. And this is a really helpful, I think is really very helpful for our trainees to hear from the people who are in senior leadership that these are issues that we've all struggled with. Practical skills, all of these: mindfulness, stress awareness, CBT, positive psychology, narrative medicine, yoga. Well, we'll come back to all of that. But building community, I think, is even more important, to expand mentorship and professional development, have some social events and shared community resources and team building activities. But it is a lot about the leadership. The leadership at any system that you're in, whether you're in an academic medical center, leadership in a department, if leadership doesn't buy into the fact that this is important, any efforts that anybody makes to try to address this are going to be very problematic. The problem is, and someone, a former CEO of a major medical organization said this to me, is that leadership can change on a dime. So that works both positively and negatively, but I can't tell you how important I think that is. And this is where our role comes in. We want to help people ensure access to care, to have screening for burnout and depression, a clear system for referrals. Well, in-house mental health services as a whole. I won't talk to this audience about that. After hours emergency lines. I mean, talking about this and recognizing the importance of mental health treatment is critical, and it's something that we've always done. But I think getting the larger community to recognize the importance of this is very significant. One size doesn't fit all. I'm going to talk a little bit about potential interventions. A group of us at GAP, which is the Group for the Advancement of Psychiatry, tried to frame this as a public health problem and talked about primary prevention, which is all of the things on the right, which is kind of what we're doing now. And then talking about secondary screening to recognize burnout and depression, anonymous third-party screening, and tertiary intervention, which is stigma-free access to care and actually having care, which we know is a general issue in psychiatry itself all the time. Self-care is not in conflict with altruism. You all know, secure your own oxygen mask before assisting others. I think that we've made this point already. I think even people in large institutions recognize that this is important. But we need to both engage in self-care for ourselves, but we need to encourage institutions to implement and support wellness and to enhance interventions. So these are all the individual approaches these are the things that most places are doing now. They're talking about understanding if you're feeling burnt out, exercise, scheduling time, having hobbies, pets, learning to say no, mindfulness. The problem with this, and I'm not saying this is bad, and I think it's good if groups and organizations provide these opportunities, is that that puts the burden back on the individual. And what we're talking about is that burnout itself is a response to what's going on in the system. But it's kind of like the general answer to metrics. It's really easy. It's easier to do this than to talk about changing the culture. But I think that's what we really have to do. And these are just examples of some individually focused programs. MGH developed a smart art curriculum, process groups, positive psychology, web-based CBT, Schwartz Center rounds. The AMA has a program called their STEPS program to prevent burnout in your practice for people in practice. Again, these are individual things that people can do. But what's really going on? What's really going on here? What leads to professional satisfaction? Time with patients, perceiving yourself as providing high quality care, autonomy and work control, that your values are aligned with the place that you're working, collegiality, fairness, respect, work content, the current state of electronic medical record usability. But what's happening is for every hour physicians provide direct clinical FaceTime with patients, nearly 2 hours is spent on the electronic record and desk work. Another 1 to 2 hours of personal time is spending each night on doing additional computer work, and burnout's increasing. And this has to do with the regulatory environment that we're in as well. So this is one of my favorite slides: organizational culture eats strategy for breakfast, lunch, and dinner. So all of these things are contributing to burnout in the environment now. Increased performance, measurement, quality, cost, the patient experience, loss of control over work, inefficiencies in the practice environment, the EMR, and the increased complexity of medical care. And this is all well beyond yoga, or as one of the residents said to me, it's not about ice cream socials. It's a shared responsibility. There's organizational responsibility and personal responsibility. And this came out of the work that's done at Stanford. And I was talking with the residents yesterday about the moral injury analogy, which I just sort of read about last summer, and I felt very compelled by it. Some propose the use of the term moral injury. Now, this is something that's been true for soldiers for a long time, which is the soldier's response to actions in war that pierce identity, morality, and their relationship to society. Physicians and other healthcare providers enter medicine as a calling. It's got some religious zeal, lost sleep, lost years of young adulthood, financial and family strain, disregard for personal health. But being unable to provide high quality care and healing in the context of healthcare, and a failure to be able to be involved in medicine as a calling creates problems. Here are the competing drivers: the Hippocratic Oath. We have to be ethical and take care of our patients. And now we're inundated with patient satisfaction, provider ratings, and review sites, which often can make it difficult for us to provide the kind of care that we really want to for our patients. Making a profit from people at their sickest and most vulnerable, which is something that we see a lot in psychiatry. And, I know here we are at Harborview, which I said was the Bellevue of the West. That's a big problem. Routinely being unable to deliver the kind of care we want to deliver. Physicians become wounded, disengaged, and hopeless. And I think this is a major challenge. And I think the analogy is apt. So what are the solutions? I don't want to leave everybody totally depressed here. Leadership willing to acknowledge the human costs and moral injury of competing allegiances. So it's really important that the leadership up there get this. And that they have the courage to confront and minimize the competing demands. Leaders who recognize that caring for physicians or other healthcare providers results in compassionate care for patients. And I sort of, this is my version of this. So the square is the socio-political reality in which we live. And I know I'm not supposed to be political in these talks, but we have to think about what our world feels like now, and what the leadership in the country, and that the impact of that on everything else that's going on. And I think particularly for those of us in mental health, we understand how important that is. So we exist in this socio-political reality such as it is. And there are personal factors, there are work environment factors, and there's the learning and the educational environment. And this is just a simple way to look at it. What are the challenges? Administrative and regulatory burden, decreased time with patients, EHR inefficiency, productivity pressures, staffing shortages, work compression with no time for reflection. And the opportunities are obviously the other side: good leadership, balanced workload expectations, adequate and appropriate staffing, offloading of administrative tasks for providers, which is a big deal. And obviously EHR redesign. I do think, and people have said this is going to happen, that someday Alexa will sit in the office and we'll talk to the patients, and Alexa will extract all the data and we won't even have to go to the computer at all. The learning and educational environment, the challenges are the loss of humanism in medicine, power differentials and mistreatment, the increased clinical complexity of patients, work compression, inadequate faculty time for teaching, and the debt burden. And the opportunities are obviously the flip side for all of that. And we're trying to work on that. And some of these are going to be short-term solutions, some medium-term solutions, and some long-term solutions, and some are going to cost more money than others. And then, of course, there are the personal factors: biopsychosocial vulnerability, stressful life events, exposure to trauma. Isolation is a really big one. Um, I think starting, we can start to really be connected to each other. I think it will help us a lot to deal with this as we try to move to change the culture more broadly. Stigma regarding help-seeking behavior we have to address. Regarding licensure and credentialing concerns, and I want to say this for everybody in the audience, and this is where I think each of us has a role to play in trying to address this issue. Art Hengerer, when this conversation started at the National Academy, was an ENT surgeon in New York who happened to be president of the Federation of State Medical Boards. And he heard this uproar about this, the licensing and credentialing concerns, and he drafted a proposal that was passed last year by the Federation, which now has a template of licensure applications that do not discriminate against people with suffering from mental illness or substance abuse problems. This is huge. 6 states have already changed their licensing applications to be in accordance with what the Federation has recommended. Now, they don't control all the states, and I think Alaska is one of the bad ones, by the way, but I'm not sure. I haven't seen the licensing application. But this is going to change. And if the licensing applications change, then the credentialing questions are going to change. And then the disability and life insurance questions are going to change. So it's not gone, but it's better. And we all, in whatever role we have a responsibility, I think, to try to do things incrementally in whatever way that we can. So obviously, time is a critical factor, and one of the pieces that I like to say, I'm sure a number of you in this room have been involved in strategic planning exercises, and people put up things around the wall, and everybody's supposed to go around the room and put a little sticky dot on their top 3 priorities, right? These are we need to go up and put things on the room and say, what can we take out of what we do? Not what do we put in, but what can we take out? So time is really pretty. Turnover results in substantial expenses. I'm just, my caveat here, everybody talks about making the economic argument to the C-suite about what we have to do. What I will say is this: we have known for 20 or 30 years in psychiatry that patients who suffer from mental illnesses as well as other medical conditions cost the healthcare system more, right? We have known that. We've had the numbers to show it. We've had the dollars to show it, and nobody's listened. It's not about demonstrating the return on investment. There is return on investment. Everybody knows that. It's having leadership who's willing to say, we're going to do that, and we're going to sacrifice something else in order to try to change the culture. So you can just look at retention. I think that goes a long way. Again, this is just more about what we can do: acknowledge and assess the problem, harness the power of leadership, targeted interventions to improve efficiency, cultivate community rewards and incentives, and value alignment with the culture, promote flexibility, resources, organizational science. I do want to say that I view this, people say, well, what do you think we should be doing? I think that these challenges in a system way are unique to location, to institution, to specialty, and even to work unit. So that what's going on in the ER is going to be different than the challenges that exist on the inpatient unit, that are different than the challenges in the community mental health center. And that the strategies and the work to try to figure out what to do has both, it's got to come from leadership that endorses a methodology and a process to look at it, and from the grassroots for the people that are involved in the problem to figure out the solution. So it's not that I'm going to be able to stand up here today and say to you, you should do this, in the Department of Psychiatry at the University of Washington. You have to figure out where the pain points are, and you guys together are going to figure out where you can start to make incremental change. This is just obvious. I've said this a million times already. So again, collaborate with stakeholders. You can establish a committee, and I think you already have people looking at this. This particularly, the ACGME has tried to push this to celebrate achievements, compensate for things, but I really think you have to engage everyone in this effort to figure out where are the particular pain points and what can you do. And I think that this is something that has to be done together. Trainees, staff, physicians. We can't have the trainees over here and the faculty over here and the nursing staff over here. We have to do this together because our fundamental job is to take care of patients. And we need to be able to do it and not at our own expense. Again, the same things that I've said before. Chief wellness officers have been touted. Tate Shannenfeld is now at Stanford. Jonathan Riff is at Sinai, but I don't think they exactly know what they're doing yet. I mean, it's good that they're in the C-suite. It's good that somebody's listening, but I think the how-to is much more challenging. I mentioned already to Mark that I would just throw up here the various assessment tools that you can look at. Again, I don't think whichever one you pick matters. I think you just need to use the same one over time. The MASLAC, this is, emotional exhaustion, depersonalization, and personal accomplishment. Those are some of the questions. The Oldenburg, MASLAC costs money. The Oldenburg is free. The Copenhagen, the Pro Quality of Life, which looks at job satisfaction and compassion fatigue, which are a little bit different than just burnout. There's a single item physician work-life study scale, a well-being index, Stanford Professional Fulfillment Index. Those are just, a few. Again, this is just it's sort of a busy slide, but it's a way to look at how key components of well-being initiatives and how you look at it over time. So preliminary steps, intermediate steps, advanced steps, but it's all just part of having a big view of this problem. This is just about the Action Collaborative on Clinician Wellbeing and Resilience. This is the leadership team. And what's important is that they're trying to bring all the stakeholders in the room. And that includes CMS, that includes the insurance industry, that includes all the Epic people. It includes everybody to try to look at this from the top down as well. And these are their goals. It's to build a campaign of system change. This is not going to happen overnight. They're doing a consensus study that should be out in the fall that'll be like To Err is Human and Crossing the Quality Chasm. Tipping the balance from burning out to burning bright. That's the hope. Somebody has to do something. It's just incredibly pathetic that it has to be us. When you come to a fork in the road, take it. I do think we're at a fork in the road, and I do think that we in psychiatry in particular have a lot to contribute to this dialogue. So this is just thank you to a lot of people, and thank you all. Yes.
It seems like underlying a large subset of the ills is our fee-for-service medical system. I'll just leave it at that. If you have any thoughts on that.
Am I allowed to be political? This is a question about our fee-for-service system. Yes, I think we should have national health insurance. Yes, I think that's part of the problem, but that's a whole political battle that, that's a little bit separate. But obviously there are challenges with that as well. But
I didn't mean to ask to.
You're right.
I mean, obviously we do. But right. I guess what I'm thinking of, are there ways that people have been able to find to effectively reduce the burden of us being increasingly forced to think in terms of, quote, productivity and billing and things?
Well, I think that's where leadership is so important. I mean, somebody was saying, and I think that this is probably true, that we ought to be, everybody's looking at the bottom line at our institutions, what's your margin? But, so I would just say, look, institutions obviously have to survive. And if you're not making enough money, then nobody has a job and we don't have a hospital and it's no good. So obviously we have to get there, but we need to look at exactly what we need to keep going. And I think the idea of nonprofit institutions that everybody looks around and says, well, we don't really think that they're fully nonprofit, particularly if there are people really, shouldn't say this, but there are many people in leadership, they're not Jeff Bezos, but they're making a lot of money up there. And, do they really need to be making that much money? Or would that money be better plowed back into this? It's just a question. I don't know, but that is a fundamental issue, and that has to do with, how our country works economically, unfortunately, I think. So, yes.
To follow up on that, what is known about how American physicians burnout rate, Canadian physicians burnout rate, and European?
I don't know the answer to that question. I've just been looking, I've just been asked to review some studies of students in other parts of the world, and their burnout rates are comparably high, at least if you look, again, given the caveats of the challenges with how we measure burnout. I don't know the answer to the question, but it would be something interesting to look at. And some of it, now, I don't know, I didn't put the slide up for long enough, but dermatology was up there in the not in the red area, but in the second worst area. It was like, dermatology, why are they burnt out? Well, it does have a lot to do with expectations. So one of the reasons that I think it makes it a little bit different to do this cross-cultural comparison is it has to do with the political environment and the expectations in a particular country. So I don't know the answer to that. Yes, well, it would be, but if you talk to different Canadian doctors, some of them think it's terrible and some of them think it's wonderful. So I don't know how it would work out in the wash. Certainly, there was a panel that we had at NYU in the fall where Stephen Bergman, who was Samuel Shem, who wrote The House of God, was one of the participants, and a question was posed to the panel, which also included Art Kaplan, who was an ethicist. Would you rather be a trainee now or when you were a trainee? And Art's response was, well, I'd rather be a patient now. So the patient, there's more cures in medicine. We're doing a really good job. But he sort of, Bergman said, no, he'd much rather have been a trainee before. But that. So we have to see. But I think there's a lot of it has to do with the loss of sense of autonomy and the ability to use our clinical judgment and not have that dictated by external sources. And we would all work hard if we thought it was worth it. So it's a very complicated situation. Nobody's burnt out. Nobody has. Yeah.
On a micro level, how do you explain the lower baseline depression being a risk factor for burnout in the resident?
Oh, this is my interpretation. I don't know if it's valid, but I think it's the change that's the problem. If you come out of medical school and this is a great achievement, you're really doing well, and all of a sudden you're faced with adversity. So I think it's the shift, and we do know that at least in trainees, I don't know if we've looked at this in the general physician population, that transition points are particularly risky. And I think that especially given a cohort of young people who've grown up where everybody got a trophy, and these kids are so high achieving. I mean, I sit on the admissions committee at NYU, and I sit there and I say, oh my God, I'd never get into medical school now. I mean, they've had success after success after success. And then you come to an environment where you're the doctor on call at night and you have a patient who dies. It's devastating. I mean, there's like no muscle. They've not had a chance to sort of build up. And I think the more that we cocoon the trainees, the worse it's going to get. So I'm very worried about that. That's why I put that curve up there. Yes.
So I have a question about your slide where from 20 to 24, doctors actually have a lower suicide rate than the general population of dentists. So there's nothing inherently wrong with us, I think, from there. And it's almost like a dose response curve. The more medicine we get, the higher it goes. And there's actually a theory about suicide that's got perceived burdenness, and there's one about acquired familiarity and just hang around death all day, and it gets easier to
I don't know the answer to that. And I think all of these statistics to some extent are a little bit suspect because, it's who tells and who says, that this was a death by suicide. We don't know about accidents. We don't know about accidental drug overdoses. We don't know those things. So I don't, to me, the game about when is it worse and who has it worse is not as important as understanding that this is a problem, that we need to try to help people seek treatment when they're feeling despondent, that we know that doctors in particular are less likely to go for treatment, and that puts them at higher risk. And there is the question of, there's moral injury, there's also the second, I mentioned just at the beginning, the secondary victim piece. It's hard to be, this is the one place outside of being at war where you're around death and dying a lot, and that takes its toll too. So of all the people in healthcare, yes.
Do you know of any place, any hospital that is doing a good job of this?
I can't name, no, I don't know. what I would say, just like, it's like all politics are local. I think what's really important is to focus on what's going on here, what the issues are for you here, and developing the solutions that are local, because they're not going to be the same. And these days, it's like, who's number one in the U.S. News and World Report ranking? Does that mean that that's the best place? I don't know. And I think it's really too soon. I think that right now, all we've been doing is educating people about the problem and saying that we have an issue with burnout, that the question of how to address this and what to do about it is still to come. So I think it's probably too early.
Thank you very much for answering.
You're welcome. Okay, welcome.